Yes.
Yeah.
Yes, Anupama.
और सुनाए, एनीथिंग न्यू?
अनुपम भी अजय हॉस्पिटल में बैठे हैं।
मैं अभी हॉस्पिटल में। हाँ जी,
हम तो घर आ गए।
मैं भी आ गई घर।
हम भी घर आ गए भाई,
कैसे?
कंफर्टेबल।
ये भी सही है। मैं ढंग से भी सो जाती हूँ, फिर उठना मुश्किल हो जाता है इस टाइम पे।
नहीं, मैं आधा घंटा सो गई थी भाई, थोड़ी सी नैप, हाफ एन आवर।
बिल्कुल।
इवनिंग ओपीडी करते हैं आप डॉक्टर अनुपमा?
नो नो नो।
अच्छा।
हाँ, एक ही बात। हाय
Hello,
मोनिका।
हेलो
Monica,
डॉक्टर
how are
मोनिका।
you? After long time, no? Nice to see you.
Same here, nice to be with all of you. बहाना चाहिए, इतने loving
बहाना
and
चाहिए।
enthusiastic gynecologist. Jalandhar group is the most enthusiastic.
आप भी कम नहीं हो।
शेयर नहीं होगा कोई
बस
बात।
मैं भी आपके साथ ही हूँ।
बिल्कुल बिल्कुल, सब साथ साथ है।
मोहितना
सबको
साथ है।
मेरे अंदर शेयर का।
चलो जी, स्क्रीन शेयरिंग हो गई।
हो गया?
या स्टार्ट।
Okay, so welcome to the IFS webinar, which we are holding in connection with the Corona. So, Dr. Aswati will be the speaker. She'll be talking about male infertility, what the gynecologist should know. And Dr. Surjit will give a welcome note now. So, Dr. Surjit is the secretary of the Punjab chapter of Indian Fertility Society. And she will be welcoming everyone.
Dear friends, chairpersons, speaker, and all the viewers on this virtual platform, a very good evening to all of you. It is my proud privilege and honor to welcome you all. Today's session, we are talking about male infertility. Male has 50% contribution in infertility. Man is very sensitive part, many times not examined properly and not investigated. Mostly men are sitting outside and the couple should be counseled together. 60% of male infertility patients can have sperms retrieval by TISA, PISA, micro-TISA, and ICSI, and they can have a child. If required, the hormones should be tested. In case of hypogonadotrophic hypogonadism, these patients can be treated with the hormones and they can have their children. In the obese patients, testosterone estrogen ratio is disturbed. It is validated to be the 10:1 ratio and can be treated with aromatase inhibitors like letrozole. Today we have Dr.
नीचे करो, आपकी फेस दिखेगी।
Oh, okay. पहले बोल देते आप। Today we have Dr. Aswati Nair with us today. She is going to highlight about the male infertility, and I welcome Madam. With this, I request Dr. Mandeep for the further proceedings for today's webinar. Thank you.
Before we thank you, ma'am. So before we start, we pay tribute to Saraswati for Saraswati Vandana. He will.
या कुन्देन्दु तुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्कर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु
So I think all doctors should have firm belief in God, and because whatever we do it in the presence of God, and everything happens with His wishes. So I invite all my chairpersons. So first of all, I will like to welcome Dr. S.S. Chawla. He's a renowned fertility specialist in Amritsar. And Dr. Monica Verma, she's a renowned fertility specialist in Patiala. And Dr. Harinder Oberoi, she's a renowned fertility specialist working in Jalandhar. I think Dr. Vani has not joined. Then Dr. Anupama Chopra, she runs her own unit and is very famous in Jalandhar. And Dr. Rakhi Goel, if she has joined, I cannot see her though. Then I will like Dr. Harinder to please introduce Dr. Aswati Nair so that she can start the lecture.
Good evening to all of you. On behalf of IFS Punjab, I welcome Dr. Aswati Nair, and it gives me great pride and privilege to welcome and invite Dr. Aswati Nair. She is multi-talented and good with known personality, and she is a great pillar of IFS. My heartfelt thanks to all of my colleagues and seniors for giving me this opportunity. She doesn't need any introduction, but for this formal introduction, she is MD Obs and Gynae, FNB in reproductive medicine. She is a clinical director and senior consultant at Nova IVF Infertility Clinic, New Delhi. She has successfully treated thousands of infertility patients from India and abroad. She has a keen academic interest and contributed to multiple chapters, publications, health write-ups. She received the Best Paper Award at ISAR Kerala State Chapter Conference for research work on embryo glue, mainly in patients with recurrent implantation failure. So Madam has used embryo glue. So Madam, we would like to just see your response in this embryo glue for embryo implantation.
Sure.
Yeah. And she has topped fellowship exit exam at IRRH Bangalore, and her area of special interest includes endometriosis, recurrent IVF failure, and male infertility. Not only she's academic, she loves to write poetry and stories. Very good, Madam. So
Thank you.
over to, so why we concerned about the male infertility? As you know, in India, more than 20 millions of patients, they are affected by male infertility. And this ratio is increasing day by day, moreover in India. I think more because of the lifestyles and use of laptop, cell phone. So India faces a high burden of infertility with couples in reproductive age. Now the experts is with us. So over to Dr. Aswati Nair for her deliberation on topic male infertility, what a gynecologist should know. So over to Madam.
Thank you so much for the kind introduction. Yes, we all are reproductive medicine specialists here, and probably just to add, I was never writing poetries in my life, but since I took up reproductive medicine, I know we all understand that this is a field with a lot of emotional baggage. तो वही शायरी आ गई.
Very good.
So with that note, I would just want to start the presentation today. I would really thank from the bottom of my heart IFS Punjab chapter for giving me this opportunity to present. Dr. Mandeep has been a dear senior, and thank you so much, Mandeep ma'am, for this opportunity. Hope I do justice with that. So starting with the presentation, male infertility management, what a gynaec should know. So, why are we talking about male infertility so much? Now, if we see the scenario world over, the world is experiencing a global decline in semen parameters. Men all over the world are experiencing fertility issues more and more. In fact, there was a study which was done in France. It found that the average sperm count of a 32 35-year-old man decreased by more than 30% from the year 1989 to 2005. So it's an ever increasing problem, not just globally, but also in India. So I have this small data that I wanted to present. So this is my clinic's data at Rajouri Garden. So if we see, so this is from 2020, we have documented the semen analysis report in terms of the sperm count. And what we found that, till last year, or, this data is for 2024, half of the year. If we see the number of males visiting the clinic with severe semen parameter abnormality or azoospermia has increased. So not only it's a global issue, but we all in our clinical practice is dealing with more and more male infertility patients. Now coming to, as we start everything with the anatomy, so let us have a brief account of the anatomy of the reproductive system. And here again, I would have some salient points to make based on the clinical significance of that anatomical part. As we all understand, the primary gonad here is the testis. We have the men have two testes, left and right. So these testes, they are basically a convolution of seminiferous tubules. There are around 800 to 1000 convoluted seminiferous tubules in the testis, along with two specialized cells. One is the Sertoli cells, which helps in spermatogenesis, and the other one is a Leydig cell, which helps in the production of testosterone. Just posterior and above the testis is the epididymis, where the seminiferous tubules are even more convoluted. This epididymis then convolutes into a vas deferens, which is around 30 to 40 centimeters long and around 1.2 millimeters in diameter. And the whole transition time for the sperms from the formation in the testis through this whole reproductive pathway is close to around 74 days. And that is the time when most of these sperms encounter oxidative stress or oxidative damage, which has a clinical significance. Now, this vas deferens, then multiple glands open out into the vas deferens. So this is seminal vesicle, which is opening into the vas deferens, and seminal vesicle contributes to fructose, which is important in the sperm's motility. This then further goes down and the prostatic glands open into it. Then it converts into prostatic urethra. It converges into the penile urethra, and then the ejaculate happens. Now coming to the internal anatomy of the testis, these are the seminiferous tubules, and there are around 800 to 1000 of them. So these seminiferous tubules are actually the seat of Sertoli cells, which are responsible for spermatogenesis. So when we talk about surgical aspiration of sperms, it is these seminiferous tubules that we are targeting, and we are trying to take them out of the testis and trying to look for spermatogenesis inside them. Now, as we all understand, and as in the female reproductive system, here again, the hypothalamo-pituitary gonadal axis is persistent. So GnRH, which is produced from the hypothalamus, acts on the GnRH receptor, which further acts on the pituitary, resulting in the production of both FSH and LH. Now, FSH acts on the FSH receptors, which are in the Sertoli cells, and this prompts spermatogenesis. While the LH hormone acts on the LH receptor and stimulates the production of testosterone. Again, there is a negative feedback, and there is a clinical significance to this negative feedback mechanism as well. As we all understand that many young boys today are, addicted to gymming and, bodybuilding. So the protein supplements that they take, and because of the anabolic effects of testosterone, most of these protein supplements are mixed with testosterone. And so these guys take testosterone at a higher level. So when the testosterone levels in the blood is higher than physiological levels, the GnRH downregulates the secretion of FSH and LH both from the pituitary gland. And this decline in the FSH levels causes decreased spermatogenesis. So this is one thing of clinical significance, and it is quite rampant in today's young generation that we see in the OPD. Now coming to the contents of semen sample. So semen contains spermatozoa suspended in a fluid medium referred to as seminal plasma. the seminal plasma component of semen provides nutrients and protection to the spermatozoa in the female reproductive tract, and it also protects the spermatozoa from the acidic environment in the female genital tract and possible DNA damage because of that. Seminal plasma is composed of fluids secreted by the testes, the epididymis, the seminal vesicles, the prostate gland, and the bulbourethral glands. The fluid secreted by the seminal vesicle makes the majority of the seminal plasma and is high in fructose, which is important for the sperm's motility. Now, if we understand the percentage of infertility that is caused because of a defective semen parameter from the male side, it accounts to almost 50% of cases of infertility. It could be either combined or solo. Now, hence, delaying the testing of a male partner is not wiser. Now, coming to causes of male infertility, the causes could be divided into pre-testicular causes, testicular causes, and post-testicular causes. In pre-testicular causes, if we start with the endocrine cause, right from the hypothalamus level, we have hypogonadotropic hypogonadism happening. Hypothyroidism again can cause defective spermatogenesis. Hyperprolactinemia again gives rise to a condition similar to hypogonadotropic hypogonadism and can result in defective spermatogenesis. Diabetes mellitus is a condition wherein the spermatogenic production or the production, motility, and as well as the morphology of sperms can get disturbed. Then coital disorders can also result in male infertility, and this could be in the form of erectile dysfunction or ejaculatory failure. Coming to the testicular cause, it could be a genetic cause as in Klinefelter syndrome or a Y chromosome microdeletion, or there are some genetic conditions like Cartagenes syndrome, which is also called as immotile cilia syndrome, wherein there is a defective in the cilia or defective in the tail of the sperms, resulting in 100% immotile sperms, resulting in infertility. These patients could also present with azoospermia. Now, coming to the congenital causes, it could be cryptorchidism. It could be an infective cause. Infections like mumps are very notorious in causing mumps orchitis, which can result in male infertility. Vascular causes could be associated with torsion, presence of varicocele. Varicocele again because the local testicular temperature is risen. Because of this, the spermatogenesis can get affected. Also, because of the defective venous drainage, the toxins that are present that can again result in defective spermatogenesis. Also, there could be some immunological cause like anti-sperm antibody, which is now considered a little obsolete, which can result in male defective spermatogenesis and further male infertility. Coming to the post-testicular cause, it could be an obstructive cause, and the obstruction could be at the level of epididymis. It could be a congenital obstruction, or it could be infective in the form of epididymitis. It could be a vasal cause. It could be a genetic condition like cystic fibrosis, where we have bilateral absence of vas deferens. Or it could be an acquired cause post-surgery, or there could be an ejaculatory duct obstruction, an accessory gland infection, which can result in obstruction in the pathway, or again, it could be immunological. Now, when we see a male patient in the OPD, history taking again becomes very crucial. So the history for this male patient should start from infancy and childhood, where we rule out a history of fetal rubella, undescended testes, history of any genital ambiguity that was seen at birth, any history of injury, history of any smaller genitalia or smaller penis, history of any cranial irradiation, because childhood carcinomas which can result, which has been treated with chemotherapy or radiation therapy, can affect the semen parameters in adulthood, or some autoimmune disorders where immunosuppressive therapy has been given to the child for a long time. In puberty and adulthood, the timing and the progression, or if there was any delay in growth, has to be noted. History of precocious puberty, scrotal pain, history of mumps orchitis, which usually happens during the pubertal age in boys. Injuries, any kind of surgeries, hydrocele surgeries are very common during this age. History of surgery for any hernia, varicocelectomy, all these things can result in infertility. Coming to the medical causes of it, there are two, three conditions are very significant. As I had already described Cartagenes syndrome, it is associated with situs inversus, chronic sinusitis, and bronchiectasis. So this is a medical paradigm by which we can diagnose it. The other conditions could be diabetes mellitus, hypertension, thyroid disorders, history of tuberculosis again, because tuberculosis again, as in females, it can cause the fallopian tube block. It can also cause vasal block in males. Use of certain medications, and here the medications, most commonly the used ones are antidepressants. They can cause semen parameter abnormalities. Testosterone supplements are very notorious in causing decrease in the sperm production, as I had already mentioned. And of course, coming to addictions, including alcohol, smoking, history of any other drug intake. There are certain occupational hazards, so occupational history becomes very important. Semen parameters are on a decline in drivers because of their constant sitting and local temperature being raised. Varicocele is commonly present in those patients who have prolonged standing, tailors, etc. These professions are, quite highly susceptible. History of radiation exposure, this could be, so I had a orthopedic surgeon whose semen parameters were so down in spite of he being living a healthy lifestyle. Probably it was a radiation exposure that they had when he was operating under CM. Frequent hot baths and tight underwear, you have to take a history of that, whether, they take very hot baths. All these has to be, patient has to be informed that, this is all not okay. And the important part here is the sexual history. Now, sexual history, frequency of coitus becomes a very important part of the history. The male needs to open up and tell you about the frequency of coitus, or you can ask a female partner about it. Loss of libido, usually males don't come up with this symptom very easily. It has to be elicited. History of erectile dysfunction and ejaculatory dysfunction again. All this, one thing about male patients are it's quite difficult to get them into confidence and elicit these histories from them. Some may open up, but otherwise they are usually very reclusive and they won't directly talk to you about them. Now, coming to the examination part, as a gynecologist, as a fertility physician, I do examine male patients. But as a at a gynecologist level, I don't know how far this examination part would be relevant. But there are a few things that can be noted. Of course, apart from the vital parameters, height, weight, and BMI becomes important, because obesity, as Madam had mentioned, overweight and obese males are candidates for hypogonadotropic hypogonadism. So this has to be kept in mind. The other signs include arm span. Arm span, because of Klinefelter syndrome, arm span is more than the height by 2 to 3 centimeters in these men. Presence of secondary sexual characters gives us an idea of how much the testosterone levels could be. Virilization again. Presence of gynecomastia could give us an idea that the T/E2 ratio is kind of getting reversed. It's quite rampant in patients with liver disease, or, on the overweight or obese side. So these signs can be picked up just by looking at the male. Local examination, not many would do at their clinic level, but the things that can be noted is penis examination, both the glans, prepuce, meatus, and the shaft. Any discharge coming out could be indicative of infection. The test is the testicular size, consistency, the presence, any epididymal pain, or the presence of the spermatic cord can be palpated. Varicocele, if present, can be elicited by Valsalva maneuver. Hernia, hydrocele, if present, can be seen. Now, coming to the investigations from the semen male partner side, the commonest investigation, or the baseline investigation, is a semen analysis, and if at all required, a semen culture and sensitivity testing. The other tests that include hormonal assessment or endocrine assessment by doing a serum testosterone levels, a serum LH and FSH levels, thyroid function test, serum estradiol levels. A T/E2 ratio becomes very important to decide which patients might benefit from the aromatase therapy, as Madam mentioned, and serum prolactin levels. Of course, viral markers have to be screened for, and screening for diabetes also becomes important. In those patients with erectile dysfunction, apart from the hormonal profile, get a fasting blood sugar and a postprandial blood sugar to be done, and a penile Doppler can help. In those patients with azoospermia, the extra investigations that would be required apart from these would be karyotyping, Y chromosome microdeletion, imaging in the form of ultrasound scrotum, and MR imaging if required. Now, coming to the semen analysis. So semen analysis is a baseline test that is done for all patients who present or the couple who comes to the infertility clinic. So semen analysis has to be done on at least 2 occasions. So here again, I have a chart wherein WHO, as per after every 10 years almost, they have come up with certain guidelines on the semen parameter level or the minimum level that is required for a natural conception to happen. So here again, we are in 2021. So this is the latest one. It's not very much different from the WHO 2010 parameters that has been put forward. So as per the 21 the semen WHO semen analysis manual, the volume has to be minimum of 1.4 ml. The total sperm concentration has to be 16 million per ml. The total sperm number remains the same as it was in 2010, 39 million sperms. Total motility of around 42% with a progressive motility of 30%, a vitality of around 54%, and normal morphology as per the strict Tigerberg's criteria of 4%. So now again, here I would like to highlight on this point, semen analysis at an IVF center versus at a regular lab. Is there a difference? Yes. Now, the possible reasons for this could be a qualified embryologist checking the sample, strict adherence to the Tigerberg's criteria, proper semen collection atmosphere and conditions. No, it is not a strategy to exaggerate the semen parameters, defects, and panic the patient. Rather, a correct semen analysis helps us to create the best treatment strategies for the couple, thus reducing their time to pregnancy. So, if at all semen analysis at a regular lab or an IVF center, always an IVF center should be preferred. Now, coming to the endocrine evaluation, it is indicated in those men having abnormal semen parameters associated with impaired sexual function and other clinical findings that suggest a specific endocrinopathy. And these are the tests, I've already mentioned them. Now, coming to a specific test and, kind of a new kid on the block, or rather something that is done very rampantly these days, the sperm DNA fragmentation index test. Sperm DNA integrity is maintained in part by the effect of disulfide cross-links between the protamines. It allows for the compaction of chromatin in the nucleus. The DNA damage could be associated with spontaneous recurrent miscarriage. Most of these men can have normal semen parameters and can be capable of getting their wives pregnant naturally. But these patients usually give a history of spontaneous recurrent miscarriage. So if you have a patient of RPL, this is one of the investigations that has to be done. Abnormal sperm DNA fragmentation has an impact on the success of IUI, IVF, and also ICSI. Sperm retrieved from the testis, because it has not undergone that oxidative stress that the sperms undergo while they take the journey from the testis to coming into the ejaculate. Therefore, the testicular sperm's DNA integrity is postulated to be much better than an ejaculated sperm's DNA integrity. Though routine use of DNA integrity test in the clinical evaluation of male factor is still not recommended. So it has to be by the history of the patient. Now, what are the risk factors based on which you can ask for a sperm DNA fragmentation index? As I mentioned, history of recurrent miscarriages, history of any infection, history of being a chronic smoker or smoking for a very long period of time, history of chronic alcohol intake. Patients who have varicocele, they can have, increased DNA fragmentation. So, and those patients who have chronic infection of the genital tract, they again can have increased DNA fragmentation. So, what are the tests that are done? There are multiple tests available. The commonly used one is the sperm chromatin structure assay and the sperm chromatin dispersion test. For both these tests, the upper limit is around 25%. If both these tests show that more than 25% of the sperms have damaged DNA, then it is considered abnormal. Now, how to improve DFI? Of course, lifestyle modification, if weight correction if required, treatment of any infections if it is there, avoidance of smoking, tobacco intake, and alcoholism. Varicocele surgery in those men where it is actually the only factor that is seen, because varicocele again can cause increased DFI, and use of antioxidants. So what we do additionally for such patients, now if such patients ends up in ICSI, we have a provision by which we can use sperm selection techniques to identify the best possible sperm for ICSI. So this I've just written as an add-on. So the tests that are can be done to select the best possible sperms are MAX or magnetic assisted cell sorting, PIXI or physiological ICSI, microfluidics or flow cytometry to select the best sperms with less DNA fragmentation. Most of these tests have have proven to be slightly beneficial, not that they have been completely beneficial even in those patients with high DNA fragmentation. Now coming to the genetic screening of an individual, when it has to be done, men with non-obstructive azoospermia or severe oligozoospermia with less than 5 million per ml, increased risk of having a genetic abnormality. Most common genetic abnormalities could be numerical or structural chromosomal aberrations. Men with congenital bilateral absence of Vas deferens could be because of abnormality of the cystic fibrosis transmembrane conductance regulator gene deficiency. Now, Y chromosome microdeletion is something that is important here. Most of the times, a baseline karyotyping would tell us the structural and numeric chromosomal aneuploidies, if there is, by which we can identify conditions like Klinefelter syndrome. Y chromosome microdeletion is a niche test wherein a part of the Y chromosome is deleted in the male. So 7% of infertile men with severely impaired spermatogenesis can have Y chromosome microdeletion. So there are three areas which can be potentially deleted. They are called AZF-A, AZF-B, AZF-C. So those with C are usually those patients with good prognosis, wherein if there's a deletion in this part, the patient usually presents with hypospermatogenesis and their chances of sperm retrieval when we do a surgical sperm retrieval is close to 100%. While deletions of AZF-A and AZF-B region have very poor prognosis and very poor prognosis at sperm retrieval even. So percentage of men with Y chromosome microdeletion increases to 16% of men with azoospermia or severe oligozoospermia. Now, I have dealt with certain clinical scenarios which in a routine gynecological practice you can encounter with a couple who has come to you for evaluation. Now, there could be issues in the collection of semen. So, what can be done? A dedicated semen collection room, well ventilated, comfortable bed or couch, attached toilet and washing area. This is sometimes very important because if you have a lab at your clinic where you want to get the semen analysis done, all these things have to be taken care of. Wi-Fi, these might seem simple, but these are important. Wi-Fi connection, relatively noise-free, calm space, adequate space that if needed, wife can accompany. Now, still complaining of difficulty, what can be done? Talk to the patient and understand the difficulty. Relax and make the patient relax and take refreshments and then try again. Coitus interruptus or use of non-toxic condoms. Medications like sildenafil 25 to 50 milligrams can be given or tadalafil 10 milligrams. Penile vibrators usually not available at gynecologist clinic, but just as a mention. And in those cases, suppose you have a level 1 clinic where you are planning an IUI and you know that a patient is having an anticipated you anticipate a difficulty in giving the sample, it's always wiser to go ahead with a prior semen freezing. Now coming to another condition called hypospermia. The World Health Organization recognizes the condition of hypospermia when the semen volume is less than 1.5 ml in a single ejaculate. So the causes of this could be retrograde ejaculation, that is semen travels back into the bladder during ejaculation, absence of seminal vesicles or vas deferens, ejaculatory duct obstruction, seminal vesicle blockage, low testosterone production caused by hormonal abnormalities, stress, period of abstinence again becomes important. If there is a shorter period of abstinence, then hypospermia can happen. Also, whenever you have this report where the semen volume is less, always ask for history of spillage because it could be nothing but just spillage while collection. Toxins from excessive alcohol consumption can affect the sperm production. And one of the things that we very commonly see in our practice is diabetes, which can again result in hypospermia. Now, coming to retrograde ejaculation, when semen enters the bladder, instead of releasing through the penis while orgasm, the process is called retrograde ejaculation. This results in mixing of the semen with the urine present in the bladder. So, usually, these patients will always either complain of anejaculation or very low volume ejaculate, and they will always tell you that after intercourse, their urine appears a little cloudy. Now, what are the causes of this? As I mentioned, diabetics and diabetes associated neuropathy is one of the most commonest medical conditions because of which we can see retrograde ejaculation. There could be anatomical defects. There could be prior pelvic surgeries in the form of prostate surgeries or urethral surgeries. Intake of certain medication or drugs like antidepressants, alpha blockers, decongestants, etc. Now, how do we treat it? Now, we have to understand that urine is usually having an acidic pH. So, if the sperms go into the bladder, they get mixed with the urine, then the acidic pH of the urine can destroy the sperms. So, one of the things that is very fruitful in these patients is to keep these patients or urine alkalinizers before you actually go ahead with a semen analysis or before you actually plan to take their semen sample for any procedure. Keep them on urine alkalinizer for around 5 days. And then initially you ask the patient to go void and come. After a post void, they have to ejaculate. And after ejaculation, they have to go again and void in a container. That container, you could have the sperm wash media along with that. And then that sample could be centrifuged and resuspended. Resuspending of post-ejaculatory urine can yield sperms in these patients. There is a technique called modified Hotchkiss techniques where what is done is the urinary bladder is instilled with 40 ml of sperm wash media. The patient is then asked to, first void and come, and then this media is instilled into the bladder through a catheter. And the patient is then asked to ejaculate so that post ejaculate, whatever sperms go into the bladder, they are actually mixed in the sperm wash media, which will be very conducive for the sperms to survive. And the third thing that is also mentioned is ejaculation on a full bladder, considering that the sphincter is now closed and the ejaculate won't go back into the bladder because the bladder is full already. There are medical management of this include use of alpha agonates, drugs like imipramine, clomifene, chlorpheniramine, ephedrine, pseudoephedrine can be used for the medical management of it. Electroejaculation is another option, and surgical management in those cases where you consider that there is an obstruction. Coming to another condition of delayed liquefaction, which we again can find in a semen parameter. So delayed liquefaction is when the semen takes longer than normal to liquefy after ejaculation. So normal liquefaction time is typically between 20 to 30 minutes. It can be present in 12 to 29% of male infertility patients, and the most commonest cause is MAGI or male accessory gland infection. Inflammation of the prostate glands, the seminal vesicles, and the bulbourethral glands. How can we go about it? Go about treating it. First, get a semen culture and sensitivity done and start the patient on the sensitive antibiotic. Fluoroquinolones usually is the drug of choice if we are not getting a culture done. Mucolytics can help these patients, but again, of questionable value. So after the semen sample has been taken and it is not getting liquefied, you can dilute it with media. You can run it through a hypodermal needle again and again and help liquefy it with a syringe. Now coming to the semen parameter abnormalities and the respective treatment. So when we talk about semen parameter abnormality, we talk in terms of the count, the motility, and the abnormal forms. So when we talk in terms of count, we have mild oligospermia where the sperm count is between 10 to 15 million per ml. We have severe oligospermia where the sperm count is less than 5 million per ml. When we talk about asthenospermia or poor motility, we have mild asthenozoospermia when the percentage of non-motile or poorly motile sperm is between 60 to 75%, and severe asthenozoospermia where immotile spermatozoa is close to 75 to 80% or even higher. Coming to the abnormal forms, now this should be as per the strict Tiger-Burks criteria. Mild teratozoospermia includes 10 to 14% normal sperms. Moderate teratozoospermia has 5 to 9% normal sperms, and severe teratozoospermia is less than 5% of normal sperms. Usually, in our practice, we will find a Siemens parameter in combination, that the patient could have a decreased count, decreased motility as associated with abnormal forms, and it could be, all these could be in permutation and combination. Now coming to individual treatment strategies. In patients with mild to moderate oligoasthenoteratozoospermia, the treatment strategies start with lifestyle modification, including weight modulation, curbing smoking, alcohol intake or drug intake, regular exercise routine, adequate sleep, and a relatively stress-free lifestyle. What are the medications that can be given to these patients are antioxidant therapies. The commonest antioxidant that we can include in the patient's diet is vitamin C, a lot of citrus fruits in the diet, vitamin E, carnitine, coenzyme Q is one of the commonest prescribed ones to be prescribed in the dosages of at least close to 300 milligrams for optimum benefit. Interestingly, a recent global survey of 1,000 plus reproductive specialists from around 88 countries indicated that antioxidants are routinely prescribed for mild male factor infertility by 85.6% of clinicians for nearly 3 months and between 3 to 6 months by rest of the 40% of clinicians. Most studies said no beneficial effects are seen in extending beyond 3 months of therapy. Now, why are we scared for this? Because there is something called as antioxidant paradox. Because as we all understand that oxidative stress related damage is a damage, but oxidative stress and apoptosis is also a natural process that body uses in their wear and tear or repair and sustainability of life. So if you use antioxidants for a prolonged period of time, there could be certain conditions which can go uninhibited, like cancers, like hypertrophic obstructive cardiomyopathies, wherein these cells are supposed to be destroyed at a regular interval, but because of the antioxidants that we are boosting the patient with, the oxidative stress or the oxidative damage to these cells becomes lesser. Now, there was a Cochrane review which was published in May 2022. Over 90 studies included 10,000 plus males on antioxidant therapy. It said that it may improve the clinical pregnancy rate, though still it is a low quality evidence as more and more robust studies are needed. Now coming to the other drugs, clomiphene citrate and aromatase inhibitor. Clomiphene citrate, as we all know, it is an estrogen agonist antagonist. It acts on the GnRH receptors. It blocks the GnRH receptors. And because of that, there is a false perception of the level of testosterone or estrogen. And because of this, the pituitary goes into secretion of FSH and LH, which again acts on the Sertoli cells and augmenting spermatogenesis and on the Leydig cells producing more testosterone. So the negative feedback mechanism, because it blocks the hypothalamus receptors, again is a little blocked here. So when we talk about clomiphene citrate, so there was this huge meta-analysis that was done with around 799 studies, wherein they found that the sperm concentration was higher during the treatment with a mean difference of around 8 million per ml. The total sperm motility was higher during the treatment, and there was no difference in the sperm morphology before and during the treatment. Total testosterone, follicle stimulating hormone, and luteinizing hormone levels and estradiol were always higher during the clomiphene citrate treatment. And this particular study, they had given clomiphene citrate over a period of 5 months. And here, when we talk about the dosage of clomiphene citrate that can be given, they say around 25 milligrams per day for around 25 days in a month with a 5-day break. Or there are a few studies which also mention giving it on an alternate day basis, 25 milligrams or 50 milligrams, depending on the body weight of the male. Coming to the aromatase inhibitor, as we all understand, aromatase is the enzyme which is responsible for the conversion from testosterone to estrogen. So, because the aromatase enzyme is inhibited, there is increased move towards the testosterone production. So, there is more of testosterone than estrogen. So, it helps in improving the testosterone by estradiol ratio, which we had mentioned. And The drugs that are commonly used is letrozole and anastrozole. Anastrozole in the dose of 1 milligram. Letrozole can be given as 2.5 milligrams for a period of 1 month. Cochrane Review 2022 said that minimal evidence supporting the use of aromatase inhibitors for male infertility in idiopathic population with normal T/E2 ratio. Aromatase inhibitors can be an off-label option for patients with male infertility and hypogonadism in men with low T/E2 ratio. These are especially those men who are borderline overweight or obese. Aromatase inhibitors can improve hormonal and seminal parameters. The semen parameters, including sperm concentration, forward motility, and sperm motility, were improved significantly after treatment. It improves the testosterone levels by 2.5 folds and repress the estradiol levels, and thus improving the T/E2 ratio. Now, again, in those patients where we have mild to moderate seminal parameters abnormalities, IUI is one modality that is very commonly used. So after the medical treatment, if there is not much of an improvement in these patients usually proceed for IUI, and that is the form of treatment that is advised for them. Intrauterine insemination is a treatment modality in subfertility cases wherein prepared semen sample is injected in the uterine cavity around the time of ovulation to achieve pregnancy. Now, two things that we have to understand is about the prerequisites for an optimal IUI outcome. The female partner should have single or both tubes patent, better with both tubes patent. The total motile sperm count of this particular semen sample has to be between the range of 4 to 9 million sperms. If this is not attained, then the IUI outcome cannot be optimal. Now, just touching upon the ART Act 2021 and what are the proposed changes in the IUI practice and what is mandatory. So, mandatory registration as a level 1 clinic is required. Gynec must be a postgraduate in obstetrics and gynecology. Mandatory staffing and equipment as prescribed, and mandatory data entry and monthly reporting to the authority has to be done if you're practicing IUI at your level 1 clinic. Now, coming to moderate to severe OATs, what can be done for these patients? Of course, medical management initially for a period of 2 months, just with the intent of improving the sperm health, followed by in vitro fertilization or ICSI. IVF is most feasible in those cases where the count is between 1 million per ml but less than 5 million per ml. ICSI is recommended wherein the sperm count is less than 1 million per ml. Sperm selection methods during ICSI in patients with deranged DFI or previous IVF failures. Now, ICSI for all is a debatable issue. As we all understand, conventional IVF has the advantage of physiological sperm selection. So, wherever feasible, conventional IVF should definitely be tried, in my opinion. Coming to the condition of azoospermia, where we have absence of sperms in the semen sample. Could be the causes of azoospermia. It could be an obstructive cause or it could be a non-obstructive azoospermia. Obstructive azoospermia includes prior history of any surgical surgeries like hernia surgeries or hydrocele surgery where there could have been a direct damage to the spermatic cord or vas deferens. Cystic fibrosis, any pelvic or scrotal trauma can result in obstructive azoospermia. Tuberculosis again can result in basal block and can result in obstructive azoospermia. Other reproductive tract malformation, absence of vas differentia, etc. Coming to the non-obstructive azoospermia, the causes include cryptorchidism, delayed puberty, exposure to chemotherapy or radiation, testosterone replacement therapy, again can result in total azoospermia, anabolic steroid use, history of mumps orchitis, heavy toxin exposure, heavy metals, pesticide exposure, etc. Varicocele is again one condition where we can have non-obstructive azoospermia because the testicular sperm production actually goes down. Coming to the investigations part, at least 2 semen analysis documenting no sperms has to be present. The presence of fructose in the semen sample could indicate an obstructive pathology. Imaging, ultrasound scrotum, karyotyping, Y chromosome microdeletion can help us prognosticate the success of surgical sperm retrieval. A testicular FNA or testicular biopsy can actually help us understand what is the possible reason for sperms not being produced in the testis. So usually in these cases, there could be three conditions. It could be hypospermatogenesis, it could be maturation arrest, or it could be a Sertoli cell only syndrome or germ cell aplasia, wherein the germ cells responsible for production of sperms are totally absent. Also, conditions with hypogonadotropic hypogonadism can also present with azoospermia, and these patients usually require a combined therapy of with HCG injections and FSH injections towards the end for a period of total of around 6 to 8 months. Now, coming to varicocele surgery again is, am I audible?
Yes, you are audible.
Yeah. So varicocele surgery, again, it is not recommended in complete azoospermia. Surgical sperm retrieval by TISA, TESE, PISA or micro-TISI followed by ICSI, or ultimately if we don't have any chance it's self-sperm retrieval, then donor semen IUI or artificial insemination donor. Now, coming to the success rate of these technologies by which we can surgically take out the sperms, the surgical sperm retrieval. TISA is the commonest procedure that is done with a retrieval rate close to 50%. Testicular sperm extraction or TESE, it is little more invasive. There's an incision that is given and it can result in around 20 to 60% retrieval. Microdissection or micro-TZ could result in around still more better chances at retrieval, maybe close to 65%, depending on the testicular pathology. And this is a micro-TZ setup in general. So what is basically being done under high resolution microscope, the seminiferous tubules are evaluated and those dilated tubules are taken out of the testis and then we subject them to examination. So these seminiferous tubules are examined in the embryology lab and sperms, if present, they can be used for ICSI either directly or can be cryopreserved. Now coming to one of the commonest conditions that can happen is varicocele. Varicocele means dilated veins of the pampiniform plexus, predominantly seen on the left side. It could be isolated right side varicocele, which could be because of a retroperitoneal mass and it needs an abdominal imaging. Now coming to the grading of varicocele, grade 1 is palpable only with Valsalva maneuver. Grade 2 is easily palpable without Valsalva. Grade 3 is large, visible through the scrotal skin. Just based on the ultrasound evidence of varicocele, you cannot label a patient as to have a varicocele. Of course, semen analysis in this regard will be beneficial. If there is added semen problem or sperm abnormalities seen in the semen parameters, then of course the diagnosis of varicocele can be clinched. Now, as per the American Urologist Association and ASRM guidelines 2021, clinicians should consider surgical varicocelectomy in males attempting to conceive who have palpable varicoceles only, not just the ultrasound or imaging evidence, associated with infertility and abnormal semen parameters, except for azoospermia males. And here, this is a moderate recommendation. They strongly recommend a varicocele surgery, that it should not be done for males with non-palpable varicocele just detected by imaging. For males with clinical varicocele and non-obstructive azoospermia, clinicians should perform varicocelectomy or in the absence of a definitive evidence supporting varicocele repair prior to surgical sperm retrieval with assisted reproductive technologies. So this is as per the expert opinion. So here I end with my presentation. I try to brush in with all the topics and just to touch upon all the possible causes of male infertility and what can be done at a clinic, at a gynecologist clinic level, at a level 1 clinic level, and at a tertiary IVF center. I hope it was useful and beneficial for all of you attending this session.
Definitely, it was an extended presentation. Very nice, completely covering all the topics. So I think there is no room for any questions because everything has been answered.
So anybody else wants to put in their own expert comments?
The speaker justified the topic very well.
Thank you so much, ma'am. Thank you. Thank you.
I think there is only one HCG injections in hypogonadism,
Gonadotropic
hypogonadotropic
gonadism. Yeah, yeah.
hypogonadism that we can use to increase
Yeah.
the sperm count, and that has helped a lot in our patients. That is one thing.
Yes, yes,
I thought
yes.
that was the only point. Otherwise, everything has been covered.
Which is the best antibiotic you use for this semen infection?
Fluoroquinolones are the drug of choice, so either levoflox or ciprofloxacin.
Okay.
But ultimately, doing a culture is more
Yeah.
better, I feel. You
It-
can't just go blind.
Dr. Monica, for IUI with oligospermia, swimmer for density gradient.
Do a density gradient always for patients when you have oligospermia. So it cleans up like those it cleans up the semen. The sample is so nice here, so it's double density gradient. And
People coming
thank
up
you so
that
much,
swim up
Doctor.
is better
Like,
because, pardon?
the topic was what a gynecologist should know. So a gynecologist has to know everything about male infertility. There's nothing that you don't have to know everything.
Yeah.
And it was mentioned in the last WHO manual, not in this one, but the last, that if you do a semen, like I have kept a microscope and I do the semen analysis, though it's done in the lab, but I do it myself. So you get the feel like how the sperms are moving and how many sperms are there, to give you an idea what's going on. And they have given a very simple, well, though you have these computerized ways and to calculate, but they have given a very simple technique. This is mentioned in the WHO manual, that if you see in the high power field, the numbers of sperms which you see and you multiply it by 4. So that is an approximate way. So you get an idea that what is the semen about, or how good or how bad it is. So for all patients who have a problem with your semen examination by yourself, I think this adds to the management of male infertility. If you're seeing the semen yourself.
Every sample before IUI, but you have to actually concentrate even on you have to see the slide yourself.
Yes.
True.
Dr. Rakhi, anything from your side?
It was a very comprehensive presentation, and it's very good to see the semen on your own if you have a microscope and
Yeah,
if you
true,
start
true.
seeing. And this is a very big problem which you highlighted, that there is a wide variation between the lab report which you do in your own center, in an IVF center, and what the common pathology lab gives. Sometimes we have to see, take the patient and show them also what the semen is showing, because they don't trust you. They think that we are highlighting.
Yeah,
And
CASA has helped
yes,
helped us in a way that we
yeah,
can, document it and give it to because
yeah.
that
And is the role of
mistrust factor is
clomiphene-
always there. They are
Is
not
there
ready
any
to
role of
believe.
clomiphene in present semenology?
Pardon?
ma'am?
Sperm parameters, role of clomiphene.
Role of clomiphene?
Yeah.
Yeah, ma'am, if
Are
you
we
really
putting
ask me,
patients on clomiphene these days? Are we putting the
ma'am, if you
patients
really
on-
ask me in my practice, I don't give it much because I personally feel it does not work. Okay. Even the evidence says that, very, it improves, but again, robust studies are needed. So that is a conclusion of these studies also. Personally, I feel if you ask me, I don't use it much in my practice because I really don't find it beneficial.
Then for
Experts.
letrozole, though, as Dr. Sujit had mentioned, especially for an altered TE ratio and in obese patients, we've tried it in many of our patients who have this oligospermia, but they somehow cannot tolerate it. They are very uncomfortable if they're giving letrozole. They have a lot of problems, and it's known for loss of libido also adds to it. So
Yeah.
it's mentioned you can give it alternate day, give it once a week, any type of dose, but it's not that easy to give letrozole to men. They are not comfortable with it, like in our experience. We haven't been able to give anyone, like we've tried it, especially there are patients who have an altered TE ratio especially with the best.
Then
But
anastrozole
it doesn't
can
work
be, I think.
practically.
Anastrozole can be the substitute.
Yes. I think
Anastrozole
tolerance of anastrozole is better, where, again, I don't use it so much in my practice, but during my fellowship days, there was a study which was done in my center between anastrozole and letrozole. So I think anastrozole fared a little better. So this was around 10 years back when I did my FNB at that time. So that fared a little better, but I still again don't use so much in my practice unless I really feel that the T by E2 ratio needs to be corrected.
And in
Yeah, and ma'am, you
semi-chronic,
had asked me about that embryo glue thing, no, which I wanted to share.
I want.
Yeah. So embryo glue actually, this study was done as a part of my FNB dissertation in 2014. So we had around 450 patients where we had included those patients. So this was at Kraft Hospital, Kodungalur, where I did my FNB from. And we had two groups. Both the groups had patients with two embryo transfers failed. So it was a mixed population. Both day 3 and day 5 transfers were included. There were mixed transfers at that time. Both day 3 and day 5 were done. And of course, the organization, I mean, they had a strict an SOP for these patients, wherein they would give, after the first failure itself, intralipids and all those confounding factors. If we ruled out, embryo glue was the only thing that was different in the two groups. Rest, there was a battery of things that was done after the first failure. So that was common in both the groups. So what I found was embryo glue was not completely beneficial, but it did improve in this subset of patients. The clinical pregnancy rate in the glue group was 45% and in the other group was 41%. It was just 4% above. So it was not at all statistically significant. It was a retrospective study, so it can have its fallacies because of that. But the patient population was 450 in each group. So that was a large, so total of around 900 patients. So, but still, embryo glue did not improve it so much. Now, after many years, I've started using it again in my practice. But honestly, ma'am, I think we have to pick our cases or choose our cases properly and then go ahead with embryo glue. Because I think any added thing that you do in your IVF program, that again brings to the table its own factors.
Yeah.
Because we had a month where we had probably a batch problem with the embryo glue, and you won't believe the patients who had opted out, like those with multiple failures who had not opted for embryo glue because of the costing of embryo glue, they fared much better than the other patients. So what we could boil it down to, that there was something wrong with the embryo glue batch. So of course it cannot be generalized over all the months, and it cannot be used against embryo glue as well. But I think all these add-ons should be used. I mean, you have to think about them and then use it, and not just use it very haphazardly and randomly.
I
Dr.
should be
Chawla?
Yeah,
Dr.
Dr. Chawla, I
Chawla?
think has left.
Okay.
Actually, Dr. Mohan Swarnakar, he used a lot embryo glue in their IVF patients, but even they also didn't notice any fruitful result for that.
No, ma'am.
So that's
It
why.
One
doesn't.
thing
It doesn't.
regarding
Dr. Chawla has
the
joined again.
glue,
Dr. Chawla has joined again.
yes.
Madam, I want to ask one point.
Hello,
Hello?
sir. Good evening. Hello, sir. Good
Very
evening.
good evening. Very informative talk. I want to
Thank you,
talk
sir.
on anabolic androgen steroid abuse. It is a common problem.
Very
Male is
common.
messy, but report is very poor. Management, apart from avoidance of the drug, what is the medical management?
Ma'am, sir, what I have found is testosterone supplements here, if we stop or maybe educate them about this and stop over a period of time, the semen parameters improve by itself.
Any medical management, madam?
HCG, sir, HCG.
Yeah, so if
This
they have
HCG
become
injections.
hypogonadotrophic
I
hypogonadism.
want to discuss aromatase inhibitor. Since in these cases, testosterone level very high, estrogen level very high, and aromatase inhibitors will down the estrogen level, and this will result in more LH, and it will result in intratesticular testosterone. The testosterone level which is already high, that is systemic, not intratesticular.
Yeah.
With
Yes,
aromatase
yes.
inhibitor, E2
Yes.
level down and more LH will come up. And this more LH will result in intratesticular testosterone, which will result in spermatogenesis. I have tried in many cases, and
How many months of therapy of how many
Okay.
months? How much time it take to regain that testosterone level?
3 months.
3 months. And without using that aromatase inhibitors, sir, without using them, how many months it take to get back to normal after
Yes,
anabolic steroids?
it will take nearly 3 to 6 months but level never come to normal. In these cases, with aromatase inhibitor, we will get better response.
Okay.
And
You have a
second
point.
question is, madam,
Okay.
second question is, in cases of hypogonadotrophic hypogonadism, FSH and HCG used. Should we use one or both? FSH,
Start with HCG.
Combined
First is HCG, and then
Start
towards the
with
later
HCG,
part,
then
you need to
add
add
on
FSH.
FSH and HCG.
in some
Yeah.
cases, only HCG can help.
Yeah.
In which cases only HCG can help, and in which cases both can help. This is my point.
So you tell. आप बताओ.
If I think in most of the cases of combined hypogonadotropic hypogonadism, if only there is a decrease in the LH or LH receptor polymorphism कुछ रहेगा, तो then probably just the HCG should help.
In cases of secondary cases,
Yeah.
hypogonadotrophic hypogonadism, then only HCG can help. And in primary hypogonadotrophic hypogonadism, both will help.
Both will help. Yes.
Okay.
Yes. Very good. Very nice. Good.
Thank you.
Dr. Monica, you were asking something or you were telling something?
I was asking, I just stuck at the glue. I just wanted to know that when you're using the glue, you straight away culture in the glue, like after thawing the embryo, you are straight away culturing in the embryo glue, or you first cultured it in the blast media and then shifted over to the glue. And if in the glue, how long do you keep it in the culture?
Yeah, ma'am, there was again this controversy in that. So initially what we used to do was we used to shift directly in the glue, give 3 hours of incubation and then transfer. So we monitored a pregnancy. So this is the latest thing that this is not a part of that study, but it's the latest thing that I experimented in the lab. So what we found was this gave us better results. And for some time we also, because we had a batch issue, so we were not knowing what was going wrong. So we tried to tweak a bit also. So during that time, what we did was after thaw, just 1 hour before the transfer, we used to shift in the glue. Okay. So, we found that, putting in the glue from the initial part of it was better. But one thing that I don't know if because very small number of patients, but what we found was when we started putting in the glue immediately after thaw, the expansion of the embryos were a little slow. I don't know if it can be clinically or embryologically correlated, but here at the clinic, we always have a protocol that we check the embryos before the transfer and make sure that the embryos are at least fully expanded before we go ahead with the transfer. In most cases, just to ensure that the thaw survival has been correct. So what we found that when we were putting it into the glue directly, we found that the expansion was a little slow. Not that these embryos did not expand or did not give a pregnancy. But yes, it's a little perplexing when you put not a completely expanded embryo, when you put a partially expanded embryo, it's a little perplexing for you as a clinician. So both ways, I think we've done both ways, and I think more or less the same. We found that putting in the glue immediate on was more better in terms of the pregnancies. But again, very small numbers, ma'am, because I use it very sparingly. So maybe around 3 to 4 transfers in a month. I do close to around 30, 35 transfers. So very less numbers. So I can't exactly tell you this.
Have you used thymosin?
No, ma'am, I've not
Hello?
yet used. Yeah, MRs are coming, but I've not yet started using. But if you guys have any information on that, I've not used, ma'am.
Anybody used?
Right. No.
We should be very careful in using these add-ons. And we should not be promising our patients empirical drugs. They should be experimented in research institutions, and then when there is some meta-analysis or some RCT or some study which gives us concrete results, only then we should. Even we did this GCSF study and it led to nothing. There was no statistically significant. And then we stopped. And I think nobody sees a benefit, even in thin endometrium, even in previous IVF failures. So anything that comes with the boom goes back with the same boom. So
exactly.
So we should be very specific and particular in using these add-ons. So thank you, everyone. Thank you very much. If
Thank you, ma'am.
anybody wants to add anything, we are still open. And otherwise, we'll finish off this very beautiful webinar. And I think Aswati didn't leave anything. Dr. Anupama listened to the whole presentation and she found out one thing that Aswati did not mention. And
Very
hats
helpful.
off,
I did touch
hats
upon
off
that.
to
but-
Anupama madam also for listening to it so specifically. It was
How
like
sincere I am.
going through the entire textbook in 35 minutes. And I think it was wonderful to have you all here. And thank you very much. Thank you.
Thank
to
you so
Corona
much.
People
Thank
also.
you.
Mandeep.
Thank you,
Yeah.
IFS
Thank you
Punjab
all.
chapter and
Thank you.
everyone. It was such a pleasure interacting. And thank you, Mandeep ma'am. She's a dear senior and will always be my go-to person.
Thank you. Thank you.
Whenever you
Sure.
get stuck.
Okay,
Thank
ji.
you.
Bye-bye.
Thank you.
Bye-bye, everyone.
Bye,
Thank you.
everyone.
Bye.
Thank you.
Thank
Thank you,
Bye.
Thank
Mayur,
you. Have a
for
good day. Bye.